The views and opinions expressed in the following program are those of the participants and do not necessarily reflect those of KSMQ Public Service Media Incorporated or its assigns.
As Congress returns to Washington from their summer recess, work continued on healthcare reform around the country. We spent some time talking with experts in Minnesota about healthcare reform and how it affects Minnesotans and people around the country. We first spoke with Dr. Douglas Wood from the Mayo Clinic. Dr. Wood addressed several questions about healthcare reform on both the national and local level.
The major problem with healthcare right now is that it's too costly, and the high cost leads to lots of other problems. It leads to access problems, so because it's too expensive, people can't get affordable insurance. Without affordable insurance, they won't go get things taken care of that they need to have taken care of. As a result, things delay, you end up in the emergency room, you end up in the hospital, and that only adds more cost. Now, cost is an important consideration because when we think about what that means, it actually is relatively simple. Although the system is quite complex, the cost issue is relatively simple. Everything that we use in healthcare has a cost. So every test, every procedure, every office visit, every hospitalization. The total cost of care is simply the product of all of those things put together times the cost. And that gets reflected back to each of us who has insurance as a premium. So we're paying for all of that utilization one way or the other. For those of us who pay Medicare taxes, then the Medicare tax covers part of that. And anything then that we want to talk about for the future in terms of cost, if we're going to add substantial cost to the system, then that's going to come back to really be an issue of how do you pay for it. Currently in the United States, we pay for health care largely on a fee-for-service basis. There are some exceptions, but for the most part, everything that is done has a fee. And the incentive then for providers is to do more. The more I do, the more income I get. And that generates excessive utilization. And all of that excessive utilization is a waste. We could use that money to do other things. Now, what we've proposed is that, in particular, we need to, as quickly as possible, implement systems in the United States that will pay for value, not for volume, but for value. And in our way of thinking, again, value is fairly straightforward. It's the output, which is the quality of care, over the cost over a period of time, say for a year. Now, in this circumstance, we're simply proposing that we attach to current Medicare payment systems a ratio or an index that will adjust the payment for value, so that if in a particular area of the country you're producing great results at a relatively low cost, you would see an improvement or an increase in your payment. On the other hand, if you're producing not so good a result at a really much higher cost, your payment would be a lot less. So that's the fundamental concept of the value index applied to something like physician payments. Well, the current proposals are to apply the value index to Medicare. Outside Medicare, you potentially could apply a value index wherever a fee schedule happens to be used. But there may be actually other more effective payment reforms that you could use to pay for value rather than just a value index. Sure. And there may be much more flexibility to do that outside Medicare than there is within Medicare. Medicare is very rigid. Its structure generally requires that significant changes in payment policy have to be done with an act of the Congress. they can't be regulated by the Secretary of Health and Human Services or the Administrator of Medicare. As a result, there are usually fairly limited options to provide some of these more significant payment reform tools for Medicare. And that's one of the concerns that we have about the current bills in the Congress now, is that there are not sufficient proposals to either improve quality, that is the big part of the value equation, or find a way to reduce the costs that would get us better results for the money we're spending. So we're really encouraging the Congress to work hard on the payment reform that would really reward value and get the message across, because if Medicare is the biggest payer, if Medicare says we're actually going to adopt this is the way we're going to do things, that will be also an impetus for other payers to do the same thing. But I can tell you that private payers, even in Minnesota, are more interested in that and have actually already taken some steps to pay for value differently than we've paid in the past. If you use the Dartmouth data, it tells you, I think, why the volume of care is very important. If you look at the expenditures for Medicare beneficiaries in the last 2 years of life, in Rochester, Minnesota, they're about $6,000 per year. Minnesota is pretty much around that. Wisconsin has relatively similar value. In Los Angeles, you're looking at $13,500 per year. McAllen, Texas, it's over $15,000. And the way the Dartmouth Atlas results are then presented, these are all patients who lived 2 years. So their outcome is the same. There's really then no difference in the outcome. So you immediately begin to ask the question, why in certain parts of the country are we using 2 or more times the amount of resources for care that are being used in other parts of the country for exactly the same outcomes? Now, if you look critically at places like Minnesota, Utah, for example, the Dartmouth Atlas has also pointed out that if you could reduce spending in the United States to the level that we have in Minnesota or Utah, you could save about 30% of overall Medicare spending. If you could save 30% of overall Medicare spending by practicing the same high-quality medicine that's practiced in Minnesota or Utah across the country, you wouldn't have a financing problem either for future Medicare or even helping to cover the underinsured or the uninsured. So this is the point that we've been making repeatedly. We're spending lots of money, but we're not getting value for the money we're spending. And it's really time that we change that, and we're going to try to really emphasize that message in the next several months, that Medicare should take the lead and really say, we expect better. We expect better value. And we're now going to begin to change the way we pay in order to achieve that. The Dartmouth Atlas has certainly helped to focus some of the attention on the delivery system. It's also helped to highlight these variations in care that occur. It makes it clear, too, that we need a combination of payment reform as well as delivery system reform if we're going to achieve the results that we would like, that is, better quality at a lower overall cost. I can probably illustrate for you the impact of higher care. So more is not better. And I saw a patient from Iowa who happens to winter in South Florida about 2 months ago. He came here because he was having blackouts. And when I asked what had happened, he had actually had his first blackout in the winter when he was in Florida. He went to the emergency room, and they couldn't find anything right away, which is fairly typical in a blackout. But they decided they should do a CT angiogram of the heart. So that is a relatively new technology. It's nice. It doesn't involve putting a catheter in, although it does involve a lot of radiation and things like that. So older gentleman now, so we would expect that on a CT angiogram there should be some abnormalities. So I said you should have a CT angiogram. So the CT angiogram was done, there were abnormalities. So then he is told, you need an angiogram of your heart tomorrow because there may be serious blockages in your heart arteries. He had the angiogram. It showed some blockages. He was told, you need to have bypass surgery tomorrow. So he had his bypass surgery. None of the blockages were actually severe enough to probably warrant bypass surgery. And our current approach, this person had no symptoms of impaired blood flow to the heart or angina whatsoever. Our current approach would be to manage those patients with medications, not angioplasty or not surgery. But nonetheless, he had his operation. He went back for a scheduled stress test a month after the operation. It was abnormal. So he was told, you need another angiogram. So the angiogram was done, and he was told, you have a blocked graft to one of the arteries that we just did. So now you need stents. So he had 3 stents put in his right coronary artery. And of course, he never had any symptoms that the surgery would help. So he comes here and he's still having blackouts. So I went through the reason for the blackouts, and at the end of that explanation, he sort of looked at me and said, so you mean I didn't really need all of that surgery? Yes, sir, you didn't really need all of that surgery. We see patients like that here all the time. A colleague of mine, Dr. Gibbons, just mentioned to me last week that he had seen an 85-year-old person who had a similar angiogram done and had lots of abnormalities, and that patient actually said, I'd rather get a second opinion before I go on. So he came here and we've taken care of that. No surgery, no angiogram. So when we talk about utilization patterns, I mean, those are the kinds of things that happen. Sure. And none of that care is beneficial. We could get rid of that, and that would not be rationing. That would be just practicing good quality medicine. That question actually has been put to me a lot lately, including by members of the Senate Finance Committee and their staff. So a couple of characteristics about Rochester and Salt Lake City that are different. One is, in both cities, care is delivered largely by integrated systems. In Rochester, Mayo Clinic, and Olmsted Medical Center. I mean, even at Olmsted, they have an integrated system. They're pretty much like we are in that regard. Even for patients who have complex illness, we share a lot back and forth. In Salt Lake City, Intermountain Healthcare is the dominant system. We know that if you look at systems across the country, they tend to do consistently better in producing better outcomes at a lower overall cost. There are probably some technical differences too. If you look at the technical capabilities in those two communities, that is Salt Lake City and Rochester, we do tend to get better technical outcomes than might be the average elsewhere. And in both of our organizations, physicians are salaried. So they're not paid on a fee-for-service basis. Can we really develop cultures like this in other parts of the country? It would be a huge challenge. Can we convert all physicians in the United States to salaried right away? Also likely a huge challenge. But I think as we look at different ways of doing things, particularly in terms of getting away from saying everything has to be billed from a visit or a procedure, then it's easier to think about getting to salaried compensation. So that might be a little easier to accomplish and transition over a period of time. Bundling, or using, say, episode-based payment, again gets you away from individual fee-for-service. So we could potentially take a patient who comes for something like a bypass operation, for example, and we could bill everything that goes into that. the initial visit with the cardiologist, all of the laboratory tests, the electrocardiogram, the chest x-ray, the consultation with the surgeon, then the hospital stay, the surgical procedure itself, the anesthesiologist, all of the hospital-related expenses, all of the medications, on a one-by-one basis, and come up with a bill at the end. And that bill would not necessarily even cover everything that would happen for, say, 30 or 60 or 90 days afterward. But with a bundling approach, what we would say is, okay, we've determined that you need a bypass operation. So you're going to get a single price for that, and it's going to cover everything that we do for up to 90 days after the operation. And if there's anything else we do, then it's not going to be billed separately. It's one price. Now, that has lots of advantage for the patient and for the payer. But it's also a pretty powerful signal to us. You better be pretty good at what you do. You better be pretty sure that you're going to get the results that you want. And you better be pretty sure you don't have complications that are going to cost you a lot of money, so that there isn't any left to build back into the things we want to spend it on, like research and education. So it's a pretty powerful message to us that we have to be really good, and we don't waste resources. We don't do things we don't need to do. We get things done as quickly as we can. We're fast in getting to diagnosis, and we're fast in getting to a good result. And it's a durable result. It's not one that's marked by having to come back to the hospital because we didn't do something right or we left something off. So that's an extremely powerful stimulus that goes into something like bundled payments or baskets of care, something like that. In the absence of an integrated system, it is much harder to make that work. There are probably some things you can do to accomplish that. In Minnesota, we are currently working on implementing baskets of care, and that's one of the implementation challenges that we will confront. But we're going to keep working at it. It's a little easier, as I say, in systems than in Minnesota. Most patients are in systems. A little more than half of the patients in Minnesota typically are cared for by a system. But if we again make changes in payment, and we begin to say to providers, we want you to work better together, do a better job of coordinating care and integrating what you do, we can think about creating some kind of entity. So one option for that is what's called an accountable care organization. So you can develop potentially a virtual system around that. And in that concept is the idea that for a modest-sized community that has one hospital, and the medical staff supports the hospital, even though the hospital and the medical staff have been separate, perhaps you could create an incentive for the hospital and the medical staff to work together. And you would make the bundled payment to the hospital as the lead of the accountable care organization, and the hospital will work with everybody who participates in the production of care to get things right. The first barrier, I would say, is that at the moment we are so intent on that is, when I say we, I should actually say each little segment of health care and everybody who uses health care is so intent on preserving what we have, and we generally lack adequate information about some of the things that are being discussed, that we're not getting to the level of discussion that we need to really make progress in recrafting the system. So a lot of the shrill arguments about this, that, or the other thing, particularly by people who are worried, and it may be perfectly appropriate because to some degree there are some important details that have not been worked out. If we could sort of step back and then stop and say, what is it we're trying to accomplish? Keep that in mind, and then say, okay, of all of the ideas that we have, how well would each of the ideas match what we want to do? So that's one of the things that we've been trying to do, is to consistently articulate that we need to make sure that providers are able to create value, and coordinate care. Everybody should have affordable insurance. Our preference is that it not be employment-based. And that the government has to find ways to subsidize the premiums for people who don't have the financial means to obtain insurance, as well as create the payment reforms for value. So that's our checklist. So once you have that and you recognize what that is, then take the first set of ideas and say, okay, if we want to look at one, in this case, one bill, House 3200, how well does that achieve what we want? And how well does, say, Wyden-Bennett achieve what we want? Or how well would a Senate Help or Senate Finance? If we could stop and simply say that, I think we'd find a lot more common ground. So I think virtually everybody agrees we've got to find a way that we can eliminate some of these unusual insurance practices of excluding people from coverage, of denying coverage after the fact, of canceling policies, of doing lots of things about payment based on what you have and don't have. And that it would be expected that there should be a comprehensive, good basic set of benefits and prescription drug coverage, and you shouldn't have to worry about losing your insurance if you move from one employer to another. And we ought to be able to say to ourselves as a society, everybody should have insurance and should actually participate for a lot of reasons. One is to broaden the risk pool, but participation also means doing things to take care of yourself. I think if you go back to that level, there's generally going to be a lot more agreement about things than there is disagreement. Otherwise, the barriers to change are largely cultural. So to the extent that you're dealing with a large part of the delivery system that is organized along fee-for-service, then that of course is going to be a barrier until we can begin to look at ways that we can say, you'll do pretty well in a different mechanism. Now, it may be that there are some people that won't do as well. So for those providers who have been solely focused on doing nothing more than generating everything they can to generate a high income, they may be very disappointed. But that doesn't mean we shouldn't move forward. We simply say, again, we're going to start paying for value. Mm-hmm. Now, if you're quite willing to do that, great. But if you're not, then there may be an impact for you.
Sure.
The other barriers sometimes tend to be political and structural. So in the Medicare program, for example, there are some long-standing silos. That is, payment is set up whether you're in a hospital as an inpatient, hospital as an outpatient, in a physician's office, or receiving home health care. And the current way the Medicare program is constructed, we can't take all of those dollars, put them back together, and say, how much would it take us to pay for the care of a patient with heart disease for a year, and then how would we redistribute that? So those are some serious structural problems that have been built into the payment system over the years, and we would ultimately need to change those as well. So the question of public option really comes back to what I was saying earlier. What is it that you want to accomplish first? And then how can you accomplish that? So if the goal is to say we need to achieve universal coverage, which is really a desirable goal, there should be affordable care, affordable insurance, and the care should be high quality. Does a public option do that, or more fundamentally, is a public option necessary to do that? There actually are a number of public options that exist now. Medicare for all is actually often invoked. So the simple question here would be, would a Medicare for all program achieve coverage, cost, and quality that we would like to see? I don't think there's much doubt that you could easily achieve coverage with some public option. However, there's considerable doubt that you would achieve improvements in quality. The discussion we had earlier about the variations in quality that exists around the country, Medicare has never been able to solve that problem. There's nothing in the current proposals anywhere that would solve that problem. And if you look at cost, then the Medicare model we know is unsustainable. In fact, in the current proposals in the Congress, there are efforts to try to make it more sustainable by reducing its costs, largely by cutting payments to providers. So Medicare has already done the experiment that says we're going to do price controls, and with price controls we're going to solve the cost problem. Medicare has done that experiment since 1992. So despite a very aggressive effort to control prices, Medicare spending is continuing to rise really at a rapid rate. So if that's the example, then I don't think the public option really is going to be the solution, which is why we've emphasized that we have to do something that's really going to get to the cost side of this. And we're disappointed that there isn't enough to really emphasize the payment for value that would fundamentally change the way that we've been doing things. So if we just keep doing public option like we've done Medicare as the big public option, then we're not going to fundamentally change the system, and we're not going to get the results that we want. We think there's a better option. If the desire is, again, to get coverage that's affordable with lots of choice, there's actually already a great connector in the country. It's called the Federal Employee Health Benefit Plan. It's the same plan that congressional members use and federal employees use. It runs with a basic benefit option that's defined across the country, and you have the choice to purchase anything else that you want to go with that. And there are more than 200 plan options that are available. It gives you guaranteed coverage, no exclusion of pre-existing conditions. It provides prescription drug coverage. It's reasonably affordable. We could start tomorrow with the Federal Employee Health Benefit Plan, and all the money that we would spend to set up this new option, we could turn around and put into subsidies for more people to buy coverage. So I'm not sure that the public option actually would achieve the goals that we would like it to achieve.